Good morning, good afternoon, good evening to everyone. And thank you for joining us for today's webinar entitled Tuberculosis and Diabetes, Why Integrated Care Matters. My name is Erin Eckert, and I'll be your moderator today. I'm the director of the infectious disease portfolio here at RTI International, where I manage multiple projects in Africa and Asia addressing malaria and other infectious disease priorities. As many of you here today already know, the connection between tuberculosis and diabetes has been known for many years. People with TB are more likely to develop diabetes, and compared to people without comorbidities, diabetes triples the risk of developing TB. And now, in the past year or so, COVID-19 has served to further exacerbate these linkages. People living with NCDs like diabetes are more likely to develop severe cases of COVID and die from COVID-19. And there is evidence that patients with TB are at increased risk for COVID-19, which unfortunately puts millions at risk. It has become clearer than ever that integrating preventive and treatment interventions to address diabetes within TB care is essential to addressing these dangerous comorbidities and achieving more equitable care for all. Health systems in low and middle income countries, however, often face challenges in integrating NCD and infectious disease care due to the siloed nature of health funding and education. Our discussion today will be focusing on this increasingly urgent issue. I am delighted to introduce our speakers today who have generously agreed to share their expertise and experiences with us. I will be introducing them in the order in which they will be speaking today. First up is Dr. Salah Ferraida, the Senior Director and Head of Medical Affairs at the TB Alliance. He is a physician with 19 years of combined experience in clinical practice and leadership roles in medical affairs and clinical development departments at multiple pharmaceutical companies across several therapeutic areas. His role in the TB Alliance includes defining the medical affairs strategy, collaborating with public health agencies, scientific community, and global partners to bring TB-approved regimens to patients. Next is Miriam Schneidman, is the former lead health scientist for the World Bank. Recently retired after 44 years, she worked on health and human development issues in Latin America and Africa regions of the World Bank. Up until recently, she worked as the lead health specialist in the Africa region of the World Bank, where she managed a portfolio of investment operations and analytical work. She has led the design and development of a wide range of health systems and communicable disease investment operations, and worked extensively on HIV/AIDS, family planning and reproductive health, and demographic issues. Ms. Schneidman represents the World Bank on the Stop TB Partnership Coordinating Board and on the Interagency Task Force on NCDs. Next slide. Elena Burham is a pulmonologist at the University of Indonesia and head of the treatment team on the Commando COVID-19 team at the Persahabatan National Lung Hospital. She has more than 16 years of experience in pulmonology and respiratory medicine. She is spearheading the fight against TB in Indonesia and has served as the head of the Infection Division Department of Pulmonology and Respiratory Medicine at the Faculty of Medicine at the University of Indonesia since 2012. She is also involved in the WHO Guideline Development Group and is a lecturer and researcher at the University of Indonesia, where she teaches and researches tuberculosis, pneumonia, and other infectious lung diseases. Recently, Dr. Burham has taken on the role as head of the COVID-19 Commando team at the Persahabatan National Lung Hospital. As an expert in infectious lung disease, she is also heavily involved in the development of various COVID-19 guidelines in Indonesia, giving training for healthcare workers, and acting as the national level advisor in creating health policy. Next slide, please. John Paul Dongo is a country director at the Union Uganda office of the International Union Against Tuberculosis and Lung Disease. He is a public health specialist with over 13 years of experience in the field of public health 11 of which are directly in the field of TB control. John Paul is the country director for the Union Uganda office, as well as the union's lead for the Sub-Saharan African Regional Child and Adolescent TB Center of Excellence, co-established with the CDC Global TB branch. Next slide. Rachel Nugent is the Vice President, Director of the Center of the Global Non-Communicable Diseases at RTI International. She has more than 30 years of experience in global health and global development as a researcher, practitioner, and policy advisor to governments. She leads a team charged with providing policy analysis, implementation, and evaluation of cost-effective strategies to prevent and control global NCDs. She also works with the World Health Organization's Global Coordination Mechanism Working Group on non-communicable disease financing and is on the External Advisory Committee of the NCD Alliance and Children's HeartLink. Next slide. Today, each of our speakers will give a 5-minute lightning talk in which they will frame today's discussion on how to address the issues of multimorbidity and share different examples of integrated TB and diabetes care, from clinical to country to global perspectives. After these lightning talks, we'll hold a question and answer session that I will moderate. We welcome you to submit questions at any time throughout today's webinar using the Q&A feature, which should be located at the bottom of your screen in the toolbar. The chat will be reserved for technical issues. So if you have any technical issues such as audio or visual connection during this webinar, please contact us using the chat feature on your toolbar, and our RTI technical experts will assist you from there. Please note that you will remain muted throughout today's webinar, so the Q&A and chat functions will be your best means of communicating with us today. And with that, I'd like to get started and welcome our first speaker, Dr. Salah Ferraida. Thank you.
Well, thank you, Erin, and good morning, good afternoon, good evening, everyone. As Erin said, there is a bidirectional relationship between tuberculosis and diabetes. And I will start my 5-minute talk with epidemiology. Diabetes is a global epidemic, mostly affecting low and middle income countries. Diabetes long-term complications are a major cause of blindness, kidney failure, heart attacks, stroke, and lower limb amputations. In 2019, 1.5 million people died from diabetes. On the other hand, tuberculosis is another major cause of death, especially in developing countries, despite all efforts to improve preventive strategies. In fact, tuberculosis is one of the top 10 causes of death worldwide. TB is the leading cause of death from a single infectious agent, ranking above HIV. In 2019, 1.4 million people died from tuberculosis, and there was more than 10 million new cases of TB. Today, the only infectious disease that kills more people than tuberculosis is COVID-19. TB is an airborne disease spread by coughing or sneezing. It can travel from one country to another, from one continent to another with ease. It's a constant contagious threat. The scope and intensity of the global TB epidemic is largely driven by the old and insufficient TB medications. Most TB drugs were developed nearly 50 years ago, 50. The current first-line TB treatment lasts for a minimum of 6 months. So novel drug regimens that include fewer oral pills with shorter duration, with higher efficacy and improved safety are needed to bring TB pandemic under control. An additional threat to be added to this is drug-resistant TB. Drug-resistant strains of TB emerge when patients stop taking their medicines before the disease is fully eradicated from their body. Remember, they have to take their medicines for at least 6 months. So these drug-resistant strains of TB can be transmitted directly from one patient to another person. In some regions, 40% of the TB new cases are drug resistant. Now, if we think about management of both diseases, in fact, diabetes can be treated, and diabetes long complications can be avoided or delayed with early detection and proper management. Tuberculosis is also curable and preventable. There is a bidirectional relationship between TB and diabetes, and they both impact the presentation of each other. TB as an infection and some anti-tuberculosis medications can cause impaired glucose tolerance, which is a risk factor for diabetes. On the other hand, as Erin said, diabetes triples the risk of progressing from latent TB to active TB with poor treatment outcomes. About 15% of TB cases globally may be linked to diabetes. And the likelihood that a patient with TB will die or relapse is significantly higher when this patient also has diabetes with TB. The increasing burden of diabetes, especially in countries where the burden of TB is still high, will further increase the TB burden in these countries and negatively affect any treatment outcome. Considering this, comprehensive screening programs might be beneficial for early detection, early diagnosis, and treatment of both disorders. We need to highlight the impact of comorbid TB and diabetes on each other and increase awareness among clinicians, among managers of national TB programs and national diabetes programs on the need and benefit of comprehensive screening for both diseases. A large proportion of people with diabetes as well as TB are not diagnosed at all, or they get diagnosed too late. Early detection can help improve care and treatment outcomes of both diseases. All people with TB should be systematically screened for diabetes. And in areas or countries with high TB prevalence, systematic screening for TB in diabetic patients should be considered as well. I would like to close my 5-minute talk with an interesting story. Screening for diabetes and tuberculosis is a national policy in India. A study was conducted and published in 2019 to evaluate the implementation of this screening national policy. The study found that no diabetic patients were screened for TB, 0, and less than a quarter of TB patients were screened for diabetes. This means that many of patients with both TB and diabetes went undiagnosed and untreated. There was almost no awareness of the need or benefit of screening. The interesting part here is study participants suggested that if screening was made mandatory, just like HIV testing in TB patients, this mandatory screening will increase the rate of screening. This mandatory policy will increase the rate of screening. In reality, screening for HIV is not mandatory in India. And in fact, it has the same status as the screening guidelines for TB and diabetes. Healthcare providers who participated in this study did not know that fact. As you can see, it has taken many years and significant resources to achieve the current level of HIV screening. Yes, it needs time for people to adopt the guidelines, but it also needs resources, funding, trainings, education, program reviews, and wider dissemination of the guidelines for this adoption to happen and happen faster. It's not just time. Thank you for your attention. Next, we will be hearing from Miriam.
Good morning, good afternoon, good evening, colleagues. I'm really delighted to be here with you. So to get this discussion started, I wanted to make three broad remarks about service integration. First, I think we all recognize that the healthcare systems in most low and middle income countries are really ill-equipped to deal with the very rapidly rising burden of NCDs, including diabetes. Most of the care is hospital-centered and costly. Hence, integrating NCD care, including early screening, detection, and treatment, offers the opportunity to invest early, to avoid premature mortality, and to ultimately contain healthcare costs. Second, and related to the rapidly rising burden of NCDs, is the whole issue of comorbidities that Salah just alluded to. I think we all recognize that patients that suffer from comorbidities such as TB and diabetes require comprehensive, holistic, and well-coordinated care, both across the life cycle and across different levels of the healthcare system. As Salah just mentioned, diabetes increases the risk of developing active TB and is associated with worse TB treatment outcomes. If we look at the projected rise in diabetes, which is anywhere between 50 and 100% for the next 20 years, it will be increasingly difficult to attain the TB elimination goals without addressing comorbidities such as diabetes. Third, from a health systems perspective, there's a potential for efficiency gains in the way the services are organized, delivered, and financed. So service integration can involve leveraging existing platforms, co-locating services, strengthening referral and counter-referral systems. The other critical point about service integration, as Salah also just mentioned, it involves inevitably additional costs. We have to train more providers. We have to establish diagnostic services, ensure access to drugs, which in the case of diabetes is quite costly and is often not covered by national health insurance schemes. And at the end of the day, monitoring TB patients is probably going to be more intensive and more costly. But against these costs, there are very important potential benefits, and that's part of the rationale behind service integration. Early diagnosis of these comorbidities, such as diabetes and TB, will lead to more rapid startup of treatment, lower transmission of TB, and ultimately better TB outcomes. So just to conclude, service integration is not whether we should do it or not, but it's really about what to integrate, how to do it, and when to do it, because there are potential benefits both for patients and the healthcare system. It is now my pleasure to turn the floor to Dr. Elena Burham, from the University of Indonesia, so we can hear more about examples from the field. Over to you, please. I think you're muted, Elena, we can't hear you.
Yeah, thank you. It is a great honor for me to be able to speak for 5 minutes in this event. This is my Indonesia country situation. TB diabetes proved to be a significant burden in Indonesia. And Indonesia is ranked 7 in the world with a staggering 10.7 million confirmed with diabetes. This is our national data in 2019. And by 2030, diabetes cases is projected to increase up to 20 million people. Even more worrying is the fact that based on our national research 2030, only 30% of diabetes patients are diagnosed. And out of those, only two-thirds of the diagnosed one is undergoing treatment. When TB diabetes coexist, as mentioned by a previously speaker, it will complicate management of both disease, decrease the quality of life, increase mortality rate, and economical burden of the country. So, our Ministry of Health has formed national guideline in managing TB diabetes since 2015. In the diagnostic state, doctor in the front line are to screen for TB symptoms in diabetes patient and perform a chest X-ray to screen for any abnormalities. But the implementation of these integrated activities are very weak. The patients are also screened using the glucose tolerance test, and patients with TB diabetes are treated accordingly to the National Diabetes Guideline and also National TB Guideline using those strategy, bearing in mind that possibility of drug interaction, as mentioned also before by Salah. And the Ministry of Health also reinforced preventive measure as a pillar of the TB diabetes collaboration, which include education of the population and BCG vaccination of infants. However, very limited health facilities provide integrated services for TB diabetes in their clinic. Case finding remain a great challenge even until today. As I mentioned before, only 30% of our diabetic patients are diagnosed, and where the rest remain untreated. Without detecting the cases means that we cannot decide who to give the care for and how widespread should the program be given. This may be caused by the inadequate access to care in most regions in Indonesia. Some of the primary healthcare facilities do not have an X-ray facilities and are not yet capable of doing the venous blood exam as their routine services. So this is our step need to be taken according to my thought. First, we have to educate the community. Second, increase awareness, use mass media, and also intensify implementation of bidirectional screening in routine care and doing training, monitoring, supervision, evaluation, giving feedback to the health services, and also ensure adequate access to adequate diagnostic measure and intervention for TB diabetes patient in all settings nationwide. Um, uh, we can also say this as a integrated approach, and also establish a quality surveillance system and research agenda to improve the program. uh, I think we also need to create a friendly checklist and other education tools. And the last one is doing 3T very massively. 3T are tracing, testing, and treating. This is a lesson learned from COVID-19 pandemic. Thank you. I offer this to John. John, it's your time.
Thank you so much, Elena. Today, I'll talk about a project titled Integrated Tuberculosis and Diabetes Mellitus Care Project that was implemented in Kampala, Uganda, to screen tuberculosis patients for diabetes mellitus. And like all the previous speakers have really mentioned, we all know that diabetes mellitus is a well-known risk factor for TB, and people with DM have 3 times higher risk of developing TB disease compared to people without diabetes. At country level in Uganda, in 2014, a national cross-section survey showed a 1.4% prevalence of DM in the general population. And the prevalence of DM among persons with TB during that time, even to date, is unknown. We just have a few findings from studies and projects that have been implemented in a few settings in the country. This particular project was a 2-year descriptive cross-sectional survey, cross-sectional observational survey that was implemented between 2016 and 2017, funded by the World Diabetes Foundation. Its main objective was to implement diabetes mellitus screening among TB patients in routine program setting, but it also sought to generate evidence for advocacy among national health authorities for further implementation and post-post scale-up. It was implemented in 10 health facilities by the International Union Against Tuberculosis and Lung Disease in collaboration with the Ministry of Health, National TB Literacy Program, National NCD Control Program, and Kampala Capital City Authority. So what did we do? We carried out sensitization of the NTP and NCD programs on the need to establish collaborative mechanisms. We also developed guidelines and SOPs, training manuals, through stakeholder engagement workshops. Healthcare workers' capacity was also built, also carried out post-training on-site mentorship and support supervision. Active DM screening was carried out for TB patients within the TB clinics. And we also established a referral mechanism between the TB and DM clinics within the health facilities. And finally, these project sites were also supplied with glucose testing strips, weighing scales, height boards, refreshments for review meetings, but they were also supplied with customized registers for recording and reporting. So what did we find? At the end of 2 years, the 10 facilities diagnosed a total of over 4,500 TB patients. And of these, over 4,000 were screened for random blood glucose. For the patients that had an RBG of equal or more than 6.1 millimoles per liter, these were recommended to access a fasting blood glucose test. Out of the 4,000 that were screened, we were able to identify 1,000 patients who were then referred for a fasting blood glucose test. And the patients that screened and had a value of equal or more than 7.0 millimoles were considered to be DM, to have DM disease. And of the patients that were screened, 92 TB patients were diagnosed with DM. Of the 92 TB patients, 88 were referred to the DM clinics for routine care. And unfortunately, 4 of the patients that had been diagnosed with DM and TB died shortly after registration into TB treatment. In conclusion, this study revealed that the DM prevalence among TB patients that were screened then was 2.3%, higher than the prevalence in the general population of 1.4%. But also secondly, screening of TB patients for DM in routine program setting with limited resources and a high HIV-associated TB epidemic is feasible. However, introduction of such innovations and interventions requires close collaboration between the TB and NCD programs and all other existing stakeholders. And finally, service-related factors are barriers to DM screening, and these really need to be addressed if similar interventions are to be implemented. Our recommendations from this particular project recommended 2 main things that need to be done. 1, bidirectional screening of both TB and DM should be considered, and we believe this should be able to identify additional TB and DM patients who can then be enrolled into care. And then also secondly, there's also need to support early detection of DM among TB patients, since we all know that proper management of these 2 conditions is a known measure that will improve treatment outcomes. with that, thank you so much for listening. Looking forward to responding to some of the questions that you'll have at the end of our presentations. I'll now hand over to Rachel for our final presentation. Over to you, Rachel.
Thank you, Jean-Paul. So it's my job to give some reflections based on what we've been hearing so far and to move us into Q&A. And I'm going to give a few reflections first about why we're talking about this topic. That's the question in the title. Why does it matter? And I think we've heard several examples, particularly based on the epidemiology. So often when there are comorbidities, and clearly here we have comorbidities that cause a negative interaction, that are really causing harm to the patient because of that comorbidity. It's not just a matter of, gee, care and treatment is more complicated, but there's a biological interaction. So it's medically indicated to be treating, to be detecting and then treating both of these conditions so that neither one of them is worsened more than necessary. So medical indication is clearly necessary, and it exists here in terms of the interactions between TB and diabetes. We also hope then that integrated care is going to be more effective. It matters because the patient's outcomes will be better. And so we want more effective care. Not doing it, not detecting that comorbidity and not treating the patient in a more integrated fashion, a more holistic fashion, if you will, means that their care is not going to be as effective, and obviously outcomes will be worse. And then the other one that hasn't really been mentioned yet, except just indirectly, is we would like that care to be more cost effective. We would like the health system to be able to use its resources and achieve more, especially when resources are limited, with integrated care. So sort of stepping back, we have medically integrated rationale and need for looking at TB and diabetes together. We've been given some examples of where the care is more effective, and particularly we've heard about screening, and then we haven't heard so much about care, so I think we need to talk about that more in the Q&A. What will be different once we identify those patients that have a dual diagnosis? NCDs, one of the reasons why we talk about NCDs as a group rather than as individual diseases, we don't always do that. It's often very necessary to think about them individually and separately because they aren't always comorbid. But we talk about them as a group under this umbrella name of NCDs because they share some attributes, particularly that care needs to be over time, sometimes lifelong care and management of the condition. So there's a chronicity element. That's not so much true with TB, right? If we're lucky, then a patient is going to have treatable TB. They're going to be treated and cured in 6 months. So it's not necessarily that we're talking about lifelong care for both of these comorbid conditions, but we'd like that care to be more effective, and we'd like it to be more cost effective. And I'm going to speak to that cost issue a little bit more, because if we're only screening patients and detecting those that have the comorbid condition, but we're then not managing them or treating them in a way that takes account of the comorbidity, we're probably not going to save money. In fact, as Miriam suggested, it may cost more. We're going to have to reorganize the screening and detection system, and it may cost more because the providers need additional training. We need guidelines. It's a little bit more complicated process. So where are we going to save money? We're going to save money because the care and management is going to become better if we're doing a good job. And we'd like to be able to save money. We don't have that evidence yet. And that's one of the important things to say here, is that there's an awful lot of talk about integrated care. And we haven't really delved very deeply yet, I hope we do in the Q&A, about what integration means. What I'm getting at here is that it does mean different things for different kinds of comorbidities, for different kinds of patients in different places. It may be that screening and then referral into the right management, the right kind of care, is what's needed, and that's all that's needed. But it may be, again, especially where there's a medical indication that it's important to manage these conditions together, that the integration has to go further. And the model of integration needs to be established for this specific set of comorbidities. And we'd like to be able to say, therefore, we're going to be able to do it in a more cost-effective manner. And there are a number of projects going on, particularly around HIV and different NCDs, where we're demonstrating that we can do it more cost-effectively if we do it in an integrated fashion. That measurement of cost effectiveness hasn't gone yet very far into other kinds of comorbidity situations, such as we're talking about today. So partly I'm here to advocate for including a measurement of costs and cost effectiveness when we do integrated care. But also partly I'm here to say there's no guarantee of that. Okay, we may not save money, we may not be as cost effective as the situation, the management that exists now, but the patient outcomes will be better. And that's really important too. So last points here before I turn over to discussion. I just want to say we've been focused on lower resource settings. These are the examples that we've heard about, but it's really important to say that in high income countries, we face challenges too in managing comorbidities. I mean, I don't think anybody has to be convinced of that. We're not doing a great job in high income countries. So there's no magic that we can just transfer somewhere else. I will be very brazen here, perhaps politically incorrect, and say I think that a big part of the problem lies with the medical professionals, with the doctors, because both of these conditions tend to be treated by specialists. And as soon as it gets into the hands of specialists, it gets separated off into specialty clinics, and people have a very hard time navigating across and between specialty clinics. So we want to talk more about primary healthcare and what can be done at the primary healthcare level. And then finally, and we know this all as well, funding streams. We have very separate funding streams, particularly when some of the funding is from external sources, from donors. They're not very interested in talking to each other about different diseases that they're not necessarily prioritizing or focused on. So that is an area that has to be dealt with. And it's very important that countries such as Uganda, such as Indonesia, and there are many others that have significant burdens of diabetes and TB will speak in a very direct way to their funders, if they have external funders, and to their managers within ministries of health who are in different divisions, and say, look, we are not achieving the best outcomes we can. We have to get together in the way that we were hearing from the guidelines in Indonesia that Elena talked about. That needs to become, we can learn those lessons from Indonesia and elsewhere, and that needs to become more widespread so that we aren't letting the specialists and the funders dictate the patient outcomes, because they won't be optimal. Over to Erin for our Q&A. Thank you very much.
Thank you very much. And thank you to all the panelists. What fascinating perspectives you all have on this topic. And I've been learning so much just listening to all of you speak. We would now like to open the floor for the Q&A. As a reminder, if you would like to submit a question, please use the Q&A tab located at the bottom of your screen on the toolbar, and we will be taking questions from that list as we go through. And I'd like to kick us off with a question that actually goes out to all of the panelists, so anyone can feel free to answer. And that is, what would be the one thing you suggest that most needs to happen to support countries on developing integrated care? If you had your wish list, what would be the one thing?
Maybe I can get us started. I'm not sure if there's one thing, but I think a good place to begin is to do a health system readiness assessment for change, right? You need to have a clear rationale for why you are integrating. You need to make sure that what you're proposing is acceptable it's compatible and feasible, and that you have the health sector capacity and the resources to, to undertake that integrated care. So to me, that's really an important place to start, an assessment and a change team. Very often you have winners and losers when you integrate, as Rachel alluded to, you have different specialists and you're stepping on their toes. So you also need a strong change team to drive the integration process. Thank you.
John Paul here, and just really to add to that, I also think that there is need to strengthen comprehensive collaboration between health programs, Ministry of Health, interventions, and other stakeholders. And with such comprehensive collaborative mechanism being put in place, these groups would then be able to spearhead advocacy with policymakers to support implementation of integrated care and scale up where possible. So I also think, in addition to my previous speaker, that could also be the other thing that we could really look out for and support Ministry of Health programs to look out for and do. Thank you.
Thank you. Would anyone else like to say what's on their specific wish list? If
I'll
not,
just jump in and say I would like to hear more about studies such as the one Jean-Paul described, where we're actually getting some good numbers, good surveillance, so that we have a better understanding of the magnitude of the comorbidities in different settings and different kinds of populations. I think it's really important to be able to quantify the issue. It may be small, and it still needs to be addressed properly, but it may be much bigger than we know. And as we are aware, diabetes is now a problem across the globe, and it's growing because the risk factors and drivers of diabetes are everywhere. And so I don't think it's going to go away. And I think that if we can measure it better over time, then we will provide more compelling arguments for addressing this in a more holistic, integrated way. Over.
Thank you, Rachel. That's perhaps a good segue to a couple of clinical questions that we've received through the Q&A. And I'd like to perhaps ask Salah to jump in as one of our clinicians, or Elena, if you'd also like to chime in. And those two questions are, is there a distinction between type 1 and type 2 diabetes and the increased comorbidity risk for TB? And then secondly, in a TB patient, do you repeat the diabetes test after or during TB treatment to confirm the diagnosis of diabetes? So two more clinical questions, if you would.
So I can speak to the first question here. I will start with type 1 and type 2 diabetes are both immunosuppressive disorders. When we speak to the global pandemic of diabetes, it's mainly driven by type 2 diabetes, because of the lifestyle and everything. Type 1 diabetes is more of immunological reaction. You cannot prevent the occurrence of type 1 diabetes. So mainly the global pandemic is driven by type 2 diabetes. However, both are progressive chronic disorders, and both are immunosuppressive disorders, just like HIV. So for this question, both will be a risk factor for developing TB, just like HIV. I just want to mention that HIV could be more associated with TB because it's a more immunosuppressive disorder. But if you look at the population level, and because of the greater numbers and prevalence of diabetes still is a significant driver for TB infections because the prevalence of diabetes, either type 1 or type 2, mainly type 2, is higher than HIV. So both are immunosuppressive disorders, and both will increase the risk for TB because of that.
Either Salah or Elena, on the second question, is there currently a recommendation about repeating diabetes testing after or during TB treatment? Elena, I think you're still on mute. I see you're trying to respond. There we go.
Thank you, Erin. So we can divide it this into two different things. If we deal with TB sensitive patient or the regular TB patient, then to suspect the diabetes condition, we first try to take a history taking, and if there is a suspiciously the diabetes condition, then we check the blood testing or proceed with other diabetes tests. But yes, sometimes there is also a tricky condition, you know, that TB patient usually having a loss of appetite. They don't eat well, so sometimes the blood, the sugar blood test result do not really represent the real condition. So sometimes if they can afford it, then we proceed with the other test, HB A1C. But if we cannot do that, then after 2 months of treatment, we sometimes repeat. Since after 2 months, uh, the appetite and the condition of the patient is getting better, they actually in the normal condition, so we repeat the blood glucose test. Yeah, this is for the sensitive TB patient, but for the drug resistant TB patient, we do the blood sugar test for everyone. Especially in our data show that almost 35% of our drug resistant TB are diabetics patient. So we do it to everyone, regardless there either there is a symptom or not. So this is like a baseline data, and we check that also regularly. Yeah, that is what we do, what we practice in my hospital.
Yeah, actually, this is a very good question, and thank you, Elena. Just at what Elena said, that TB as an infection could cause impaired glucose tolerance. So sometimes during the active phase of TB, you can see transient hyperglycemia. That's why the recommendation is to repeat the diabetes testing to confirm after the treatment of TB, because any infection like TB and some anti-tuberculosis medications could cause transient hyperglycemia in some cases. So we will recommend reconfirming the diagnosis of diabetes after the treatment of TB, in addition to what Elena mentioned. But thank you. This is a very good question.
Yes, thank you. This is very illuminating to hear from the clinicians about some of these specific tests, and actually leads nicely into a couple questions that are in the Q&A, which ask, I mean, you've mentioned the challenges of being able to do the diabetes testing in the TB context, specifically in lower or middle income countries. So a couple of participants have raised questions about, is it possible to consider diabetes and TB bidirectional screening and management, specifically testing supplies, et cetera, in a global fund grant? And how would one go about ensuring that some of these needs are included so that countries have the funding to provide these services? So any thoughts from our panelists on how to incorporate this into this idea of integration of these two disease areas into a global fund grant or other funding agencies as well? Please go ahead, Arlena.
Well, I think if we can show the data how big is the problem of comorbidity of a TB and diabetes, I think the donor should willing to support the activities to implement the TB diabetes activities to overcome the problem. Otherwise, well, this is just the same thing with you mentioned that in many hospital, especially I think Miriam was mentioned about this, that the patient diabetes and TB were treated in different outpatient, which is this is a bit not what is not, I'm not saying annoying, but not very convenient to the patient. Sometimes even the TB doctor just treat TB without really taking care of the diabetes, or even the diabetes clinician only focus on diabetes. So since this is the complexity, I think TB diabetes should be integrated in one clinic, not in separate clinic. So we have to raise this condition to the donor, whether Global Fund or USAID. So maybe they will aware of this condition and willing to support the grant for these activities.
I'll jump
Thank
in
you.
just briefly on that, Erin. And
Please, go ahead.
I'm not an expert on applications to the Global Fund, but I do know that relatively recently the Global Fund is accepting country applications to support programs that are integrated, that include NCDs, if you can show that outcomes for patients with the three major diseases of concern to the Global Fund, HIV, TB, and malaria, if outcomes for those conditions are improved. And we've already demonstrated in this webinar that that would be the case. Of course, it depends on the details of how you organize that and so on. But the Global Fund does accept applications that include attention to patients with those NCDs, with those comorbidities. So I think that's very encouraging. I don't know the details. Nobody's going to bet the farm on what I say about this, I hope. But I do think, less facetiously, it's really important that countries that need this kind of support for the comorbid conditions amongst their population talk to the Global Fund about it and learn what's required, learn what's needed to be able to demonstrate that those resources will be well used for those patient outcomes. As this is relatively early days for the Global Fund to be supporting this kind of arrangement. Thanks for the question.
Yeah, Erin, I just wanted to jump in very quickly. I think we really need a paradigm shift in the way that donors provide financing, right? We need to get away from focusing on diseases and focusing on patients. And it sounds trite, but it is so, so critical for all the reasons that we heard earlier. I just wanted to say a couple words about what we're doing at the World Bank. A lot of the work that we do is providing financing for integrated care models. And we both work on the service delivery side and on the health financing side, because you need reforms in both areas to really improve health outcomes at the end of the day. And we have a whole range of projects from countries like in Kenya, where we're integrating NCD care onto HIV/AIDS platforms through task shifting, task sharing, strengthening referral systems, integrated patient management systems, patient support groups, to change behavior and to raise awareness, and also to encourage them to enroll in the National Health Insurance Fund. So from Kenya, you go all the way to Eastern Europe, where we're helping countries to completely reform their primary healthcare systems, setting up primary health family practices, gatekeeping at the hospital level, changing provider payment mechanisms and provider incentives to incentivize this kind of integrated care, feedback mechanisms, and so forth. So we at the bank have the flexibility to provide funding which is not earmarked, which really takes much more of a patient-focused approach and a health system approach, that at the end of the day really enhances the chances of better outcomes and hopefully moves towards more cost-effective interventions. Over to you, please.
Thank you, Miriam. I think this sort of paradigm shift, as you've been suggesting, is actually highlighted by another question in the Q&A that one of the participants wrote in and said, does the current pandemic of COVID-19 give us an opportunity to call for normative guidance, funding, basically the paradigm shift that you've suggested, Miriam? Is this our opportunity now to ask for integrated approaches across the HIV, TB, COVID, diabetes sort of spectrum of things that we might be seeing? And I'd love to hear any of the panelists who'd like to respond to that question. How can we leverage the current COVID pandemic to bring in these integrated approaches? Would anyone like
I
to?
think, what I'm seeing, from the ground is this emphasis to build back better. And I'm seeing some concrete examples, some countries like Rwanda and Kenya and other countries in Africa, whereby they're providing drugs for longer duration. They're doing more telemedicine visits. They're screening patients so they don't have to come to the facility as often as they did before. So there are certain elements and strategies that are being used that ultimately will provide better patient care and will save resources and will help us to deal with these chronic conditions. So there are a number of concrete examples that are encouraging.
I guess I'll jump in. I can't resist the opportunity. I wanted to let others speak first, but just to build on what Miriam said, I think it is absolutely imperative that we take this opportunity to highlight that this coexistence of infectious diseases, whatever it is, whether it's TB or whether it's HIV or whether it's COVID, with in people who have chronic conditions, who have NCDs, this is not just a 2020 phenomenon. This has been around. We just haven't been measuring it, and we haven't been setting up our healthcare systems in order to deal with it very effectively. So I think it is a very essential moment to get that paradigm shift, if you will. And I think, to Miriam's point and to what we heard from Elena and Salah and John Paul, the ways to do it will come from the systems themselves. They'll come from what people are doing in the countries that make sense. If the barriers are removed, if they're encouraged, if there's better surveillance so that we actually know how to better target the most vulnerable, because that's what COVID requires. We're not going to we shouldn't have been treating everybody with COVID the same, right? Because and detecting it in everybody in the same way, because people who live with higher obesity, who have existing respiratory conditions, who are already immunosuppressed, those are the people that need to be targeted, that are most vulnerable. And that will save more lives, and that will save costs in the system if we reduce the most severe cases and people in ICU and who need oxygen. So I think we have lots of reasons. We don't have the time to go through them. I will stop, I promise, right now, Erin, but that's a really important, this is an important moment. That's an important question.
I think, thank you, Rachel. I think your remarks are actually an excellent summary. And we are almost at time. I was scanning through the Q&A and I noticed a number of requests of people looking for sort of clinical guidance around how to do this integration. When do you screen for TB or for HIV in a tuberculosis patient? Are there some protocols, recommendations, et cetera, that could be followed? So I'd like to suggest that if you or your organizations have those type of recommendations, protocols, resources that could be shared, please send us links and perhaps we can compile them and send them back out to all the participants on this list, because there's quite a number of questions coming in around that. And unfortunately, we don't have time. I mean, we're just getting going, I feel like, so maybe we'll have to do this again sometime and focus on some of these other fascinating issues. So we don't have time to get to all the other Q&A. This has been recorded, so we will be able to share this with people who are not able to join us today. So I'd like to just take this opportunity right now as we conclude to thank our speakers, our participants, and the team at RTI behind the scenes who helped to organize this. We look forward to continuing the conversation about integrated care for infectious diseases and non-communicable diseases in the future. Please take the time to fill out the short feedback survey that will pop up in your browser after you close this window. We will be emailing you the results of this session in the next week or two. And if you have a few of those resources, protocols, etc., to share, we can include that in the emailing to the participants. So in conclusion, be well, take care, and thank you again. This has been really a valuable session this morning.
Thank you.
Thank you.
Bye.
Good day,
Thank you.
evening.
Bye-bye.